All right. Well, welcome everyone to our next Board of Governors exam preparation session. I am here today as one of your hosts, Olivia Parker, along with my co-host.
I'm Dr. Jaime Nietos here.
Yes, and we also have our committee members. Mary is also here with us, as well as Grace St. Clair, who will be presenting on the HR portion of our examination today, prep course today. So with that said, I have the pleasure of introducing Grace to you guys. Um, Grace is a quality and compliance director with over 17 years of experience implementing and managing comprehensive compliance programs, including HIPAA privacy and anti-fraud initiatives. Grace has a proven track record of ensuring alignment with regulatory requirements and organizational objectives, developing annual compliance programs, and fostering a culture of integrity and ethical behavior within organizations. Born and raised in San Francisco, Grace earned a bachelor's degree from the University of San Francisco and a master's in health administration from California State University, East Bay, where she has been an adjunct professor for over 16 years. A lifelong student, Grace is working toward her law degree at Purdue University with a focus on healthcare law to enhance her skills and knowledge about healthcare compliance. Without further ado, I would like to introduce Grace to you guys so she can kick us off here.
Thank you so much. Welcome. Happy Saturday to everybody. I am going to go over the human resource portion. As you guys just heard, I'm not in human resources, but working within compliance and quality, we always touch base and have a lot of talks with our HR professionals, along with everything in terms of regulations and everything that goes with it. So hand in hand, working with our HR professionals all the time. So I will just kind of jump right into our questions, and we'll kind of go there. So here's the human resource, just a little bit of information. I won't go through this whole thing, but just knowing, what human resources is about, recruitment, retention approaches and techniques, also knowledge of performance management systems and employee motivation and development principles and techniques. So I will go on to the next a little bit. There's a little bit more information there. So with the first question is, which of the following is typically performed during a background check? So what I kind of like to look at with this question, looking at what are the key things that you would look in a background check. And when I look at, verification of personal finances, I don't know if I would really want everybody to look at my personal finances unless I was in a financial position. Maybe if I was a CFO, I could see that because you're managing money. Involvement in religious or political activities. I don't know if that would be really actually relevant. Again, that's your personal life, so I'm not sure if that would even come into play. Previous employment or education claim. So I would say that would be something I would definitely think to look in a background check. And then prior performance evaluations. So when I look at that question, I would think maybe if it was, I don't think the prior performance evaluations would be in a background check. I think that would be more for if you're trying to prove something or maybe, want to show some of the work that you've done or, been recognized for. So I don't know. I can't see the chat, so I'm not sure. I should probably pull that up on the side. Hold on. See what everybody's thinking. So yeah. So a lot of C's in there. So, and that's what I would pretty much go for. So let's see what the answer is. And it is C. So yeah, previous employment and education claims. I know that a lot of jobs do look at that, and they'll look at your education and what you've been doing. All right, the next one. Okay, so the primary purpose of a well-developed performance appraisal system is to, so well-developed is a key word that I would be looking at. So A is compare employees across the organization. I don't know. I'm not sure about that one. Provide employees with developmental feedback and guidance. I think that's very important. I know just as for myself, I like to always have that feedback and guidance from my supervisors. C, ensure employees understand the job they are supposed to be doing. I think that's important, but I'm not sure if it would really fall into the performance appraisal system. And D, determine how well management engages employees. So, looking at the chat, B seems like the popular answer, which I completely agree with. Let's see what the answer is. So yes. So I think that is, really important and relevant, making sure that these employees have that feedback and guidance so that they know what is expected, what they need to do for future. So, all right. So next, number 3. So with growing frequency, employees who have been dismissed are resorting to lawsuits for redress. In such cases, the court may find in favor of the plaintiff if the employer dismissed that plaintiff. Okay, so a lot of words in there, which I've been thinking of lately since I'm in law school. So for A, for cause, but without using progressive discipline. Okay, without cause. B, that one sticks out to me. C, before the end of the plaintiff's probationary period. And D, for union organizing activities. So looks like B seems to be a pretty popular answer here, and I think that it holds true to that, which I would definitely say without cause. But let's see if that's correct. And it is. Okay. So next question, moving along here. So which of the following would be considered the most effective approach to preventing the need for employee disciplinary action? So what would be considered the most effective approach? So just like some of those keywords that kind of have to stick out. So the most effective approach. So A, having an accurate job description. I think that's really important. B, having an employee orientation program. It's important as well. I don't know if it's the most yet. C, implementing a performance-based compensation system. Okay, I can see that could be very important as well. D, giving a managers a small span of control. So just looking at the 4 questions or 4 answers that we have, I think the most effective approach and just looking at is definitely looking at, or I would go with A, having an accurate job description. It looks like a lot of folks are answering A. I think that's really important because you need to know what you're expected, to do. And it is A. Good. All right. Moving along. So 5, which activity should precede the beginning of a recruitment process for a new employee? A, obtaining information from employees in a similar position to assess the validity of the job description. So which activity? Okay. And this is like my approach. I know everybody kind of has their approach, but I know what we're doing here is just like really looking at that question and highlighting a couple of those keywords. So when I look at this question, I would say, okay, which activity? And then I would probably say, okay, the beginning of a recruitment. So the beginning of a recruitment would be kind of some keywords that I would look at. So B, assessing the cost of various forms of recruitment. C, making a decision whether to emphasize internal or external recruitment. Or D, conducting a job analysis. So which activity should precede the beginning of recruitment. I want to look at, I'm either between maybe A and D, but I think I'm going to go with D. I think it's important to conduct a job analysis. So, okay. And it is D. Right. So next question, the evaluation of senior management is best administered A, when criteria are established and known to both parties on a scheduled periodic basis. B, C, after consultation with the executive committee of the board. And D, in conjunction with a salary adjustment. So I would look at what best administered would be the keywords that I would kind of look at. And a lot of folks are answering A, which I think is really important. I think when that criteria, or you're looking at that criteria, and both parties are knowing what their expectations are. So let's see what the answer is. And it is A. Okay. All right. So 7, the critical incidence technique of employee performance appraisal requires raters to A, select statements that fit the performance characteristics of individuals. Okay. B, select the highest and lowest performing employee in a work unit. C, record the degree to which specified behaviors are performed. D, record behaviors of employees that are related to both good and poor performance. So again, looking at the question, the critical incidence techniques of employee performance appraisals. So I think this one I looked at a couple times right now and just kind of thinking, I think it's important to record behaviors of employees that are related to both good and poor performance. I also think that I don't think that you would necessarily need to select the highest and lowest performing employee in a work unit. Possibly record the degree into which specified behaviors are performed. But just looking at what we have here, I would think the best answer would probably, for myself, would be record behaviors of employees. So I would go with D. Let's see and it is D. Okay. So our last question, according to Herzberg's hygiene and motivators theory of motivation. I learned about this Herzberg's hygiene a while ago, and I think it was in one of my books when I was getting my graduate degree. So let's see. Answers are A, cleanliness of the workplace plays an important role in motivation. B, the absence of adequate compensation can be a dissatisfier, but the presence of adequate compensation is not a motivator. C, employees are motivated by money and factors intrinsic to the job itself. D, extrinsic factors are prime motivators. So even though it says hygiene and motivators, I believe it's quite part of the cleanliness of a workplace. When I look at this question, B seems like the most accurate answer for myself. And sometimes what I see when you get these questions, just a tip that I do, and a lot of the questions that I ask, I look, okay, why is B just overly, I don't know if I want to say this, but overly worded, I guess. But when I'm stuck and I don't, this is just a tip that I have, so I thought I'd share this with you guys. But when I have 4 answers and I may not be sure of what the answers are, I usually go with the one that is a little wordy. That's just something I kind of do, and sometimes it works, sometimes it doesn't. But in this case, because it's been a while with this Herzberg hygiene and motivators, I would probably go with B or D, and it is B. So looks like we got some B's in there. So that is I think that might be it. So I don't know if there's any questions or anything that you guys may have before we move on.
I'm just curious, Grace, does cleanliness have anything to do with it? Just for my own knowledge, do you know?
No, what I remember of it, and it doesn't. So yeah, I think
Okay.
that's why it kind of throws you off, because especially working, in a hospital environment for so many years, you're like, okay, it must mean something, like the washing hands or something like that. But no, it doesn't. What I recall. So I'd have to go back and look at some of the material, but. Any other questions? All right, so we will just move along, and I will introduce Sherlivia Parker. So I'm just going to give a little background on Sherlivia right now before she goes over. So with over 2 decades of experience in clinical and administrative revenue cycle operations, Sherlivia Parker is recognized as a transformative leader in healthcare, innovation, and technology integration. She holds a master's degree in health administration and a bachelor's in science, and was honored by Marquis Who's Who in America as a leading executive in the clinical revenue cycle. A pioneer in technology implementation for the middle revenue cycle, Sherlivia specializes in designing physician-facing solutions to drive documentation accuracy, operational efficiency, and revenue integrity. As a data analytics expert, she partners with developers to build a robust interface capability, seamlessly connecting clinical, administrative, and financial systems. Her achievements include developing customized data tracker technologies for denials management and audit tracking, empowering providers with real-time insights, and optimizing claims workflows. Sherlivia's expertise spans technology integration, clinical documentation integrity, population health, coding, quality, and auditing. She excels in collaboration across case management, utilization, management, and CDI teams, and is passionate about physician education and engagement. Currently, Sherlivia is president of compliance and education, clinical revenue cycle at Medovent, hopefully I'm saying that correct, solutions, and an adjunct professor at American National University. She is also a national speaker for ACMA, ACDIS, and HIMA, advancing, sorry about that, advancing revenue cycle management nationwide. So with further ado, I will pass it on to Sherlivia.
Thank you so much, Grace. I appreciate that. So, yep, here's my bio there on the slides. We could go to the next slide. Thank you. All right, so I get to talk to you guys about healthcare technology and information management. So this is an area I'm really, really passionate about in healthcare. As we all know, technology is here to stay, and it just helps us be more efficient, especially with data analysis, data analytics. One of the things it's important to also understand is some of the regulatory requirements that technology policies that impacts us in healthcare. So we'll definitely look at some of those things as we go through the presentation today. Interoperability, of course, is a key concept when we're talking about technology and interfacing with different applications within the healthcare system. There's multiple application utilized throughout a healthcare systems, from the laboratory to our EHRs and such. So we'll talk a little bit about all those components and the knowledge of those key concepts within health informatics. So we can go to the next slide. Yes, and then of course we want to center around the impact of technology, disaster planning. If you've ever taken a computer informatics class, these are the key concepts that you'll hit on. So that's what we're doing here, right? Just to get that overall understanding of computer informatics as it pertains to healthcare. So this is our agenda items for this particular session. Everything with technology, ending with your healthcare analytics, right? If we have the information within these tools, we can definitely look at how we're doing from an analytical viewpoint for anything within healthcare, especially when it lines up with regulatory requirements. So we'll look at that. So next slide. All right, so here's our first question. A CMS program that requires provider to consult a qualified clinical decision support mechanism for the appropriateness of diagnostic imaging services is called. So we have a listing of regulatory insights here from a technology viewpoint. So here we have the Health Information Technology for Economic and Clinical Health Act. So if we look, that's our high tech, right? So high tech in itself was focused on promoting the adoption of electronic health records, right? So that one is not necessarily clinical decision support, right? That high tech really came in play probably back in 2010. So that one is probably not the correct answer, high tech A. So B, protecting access to Medicare Act of 2014. So that particular regulation was about the appropriate use criteria program. So that one itself may be um, the answer. Meaningful use was actually also related to EHR incentive programs, not not specifically to imaging appropriateness. Meaningful use, I was actually hired back at a small community-based health system where I led the implementation of our meaningful use initiatives and this small community-based hospital, we were incentivized $2.2 million. So that meaningful use was a big reason for that requirement and those incentive programs that was sort of related to the High Tech Act as well. So that one in itself didn't have anything to do with clinical decision support. And then D, we have the American Recovery and Reinvestment Act of 2009. That particular act actually provided the funding for high tech, but was not did not address like clinical decision support appropriateness for imaging. So I would say the answer to this would be B, your PAMA, which is your Protecting Access to Medicare Act of 2014. So that particular act there, the CMS was a CMS program that providers had to consult qualified clinical decision support. Clinical decision support for appropriateness of advanced diagnostic imaging. So what's the answer should be B. So okay, yes. So hopefully that made sense to you guys. So that was the PAMA Act, and it had the criteria of appropriate use for imaging specifically, and it had evidence-based clinical definitions within that whenever a physician was going to order any type of imaging, a CT, MRI, nuclear medicine, that PAMA Act ensured that they would use evidence-based definitions to use that so that we can ensure that it was appropriate use of those services and not providing services that was not appropriate from a cost management viewpoint and from an evidence-based insight as well. So we can go to the next question. All right. Number 2. The COVID-19 pandemic played a significant role in the expansion of telehealth with the 1135 waiver by. So we'll think through each option we have here as we go through it. So A, allowing Medicare beneficiaries to receive services in a designated rural area. B, allowing Medicare beneficiaries to receive services at clinics, hospitals, and certain types of medical facilities. C, encouraging a non-face-to-face communication through online portals. Or D, Medicare paying for office, hospital, and other visits to telehealth. I think a lot of people in the chat did select D, and I would say that's the appropriate answer. A and B were older, kind of pre-pandemic telehealth regulations that had limited telehealth access for rural or specific health sites. So that A and B was pre-pandemic. Those were in place. Special regulatory requirements because of rural areas and access for patients. So that it's definitely not A and B. Um, so the most appropriate answer I would say for that is D, the COVID-19 pandemic through the 1135 waiver authority significantly expanded telehealth access by allowing Medicare to pay for office, hospital, and other visits via telehealth, regardless of the patient's location. So definitely D, I would say, yeah. So D is the correct answer, and I think a lot of people in the chat had that correct. I feel COVID is still very fresh in all of our minds. So that was definitely something that everybody, at least within the clinical revenue cycle space, we were all, looking at these regulatory requirements when they came out to expand access for patients to see clinicians during that time. So number 3. Why is it important for IT strategy to align with the organization's goals and objectives? All right. So A, to increase Medicare payments. That's likely not why we would want to align. B, to improve access to data for management, providers, and consumers. I would say that that's a probably good answer there. C, to allow the CEO to control IT spending. That's logically not the best answer here. D, to give the CIO a seat on the executive committee. That's likely not the best answer there. I think in the chat, most people did have B. Let me check that. Yeah. Yeah, I think everybody in the chat. So like the B, and I would say that is the correct answer because access to the data, yes, access to the data is fundamental for achieving goals in patient care, operational efficiency, regulatory compliance, and strategic growth for sure. All right. So number 4, what competencies do not matter in selecting a CIO? Chief Information Officer. A, prior management experience. It's probably good to have when you're selecting a chief of of the information technology team. Or B, knowledge of healthcare organization and delivery. I would say that's good to have. That's a good competency to have if you're looking for a CIO. C, a personal relationship with a board member. Or D, finance and budgeting skills. I think I'm in the chat. I'm seeing some C's, and I would say uh, that competency does not matter. It's not technically a competency if you have a personal relationship with a board member. That may be good to have, but it's definitely not a competency. So I would say that C is likely the answer for this particular question. So I think Let's see what that is. Yep. So C is the correct answer for that particular question. So, all right. Next question. When introducing a new information technology system to a healthcare organization, resistance can be effectively addressed by one of the things I always talk about. I speak a lot to at different events about technology. I'm speaking next week at the Physician Advisor Forum, and I'm talking about physician-facing technology and strategies, for implementation. And so one of the things that I always talk about, right, it's people, process, and technology. So we have to think about the people that's going to be impacted by this technology first, and then process, right? How will that impact the current process in place, and how can we automate it leveraging technology? And of course, the technology comes into play after we kind of look through all of those things. So if we think about that and we're looking at these options here, eliminating existing social groups that appear within the organization, that's not practical, perhaps, and could damage morale. So B, um, employing a policy of mandated use throughout the organization. While you could do that, it's just not a best way to have employees implement technology and embrace the advantages it could bring, right? Because you want people to use it. Change management is real when you're implementing technology. So mandated use may force adoption, but it can increase resentment and reduce engagement. So you're asking for failure before you implement, right? So employing a mandate may not be the best way to approach it. RC, focusing on the system users and being responsive to their needs. So that's definitely something you want to do, right? Before I've spearheaded a lot of technology implementations across multiple different health systems. And one of the things that I always try to do in the beginning is address the concerns of the end user, right? If the end user doesn't use it, you're failed. You totally failed. I went into a large academic medical center where they had implemented a physician-facing technology, and it was failing. I came into a really tough situation. But what I noticed, they didn't even focus on the providers, and the mid-levels and the physicians who had to engage with that. They just rolled it out, right? They didn't focus on that end user needs, the questions they had, and how to respond to that. And so what I did when I came in, I pulled it all the way out, I stopped the use, and I re-engaged with the providers, focusing on their needs, what we were trying to do, because it was really to decrease physician burnout, to have real-time AI, clinical decision support nudges within the clinical documentation space. And once I did that, I was really able to get the physicians to embrace the technology and use it. It was a full transformation, but I couldn't have done it if I didn't focus on them as the system users, right? The end users of the technology. So I definitely will say C is right now my choice as the correct answer for this particular question. Rapidly introducing system changes to allow the staff to see the cost savings. Okay. When it comes to an end user using technology that's going to impact their workflow, we're human. How is that going to impact me? Cost savings is something from a managerial viewpoint, an executive leader viewpoint we're looking at, right? And I think our staff members will embrace that in the end. But that can lead to confusion and higher resistance, and inadequate preparation and support, right? If we're looking at cost. that is always an end byproduct of what we're trying to do when we implement technology. But our first concern should be the people that, where that's reporting to us and that's going to be impacted. So I would say C is probably the best answer. Yes. And so that's the answer we have, which is the correct answer. You always got to focus on the people first. If you don't remember anything, it's always people first, process and technology. And it's a continuing cycle because when you implement technology, the process could change, right? As you continue to evolve and leverage the full capacity of technology, because a lot of times I've spearheaded and implemented a lot of different technology and health systems. And a lot of times we scratch the surface on the implementation and the functionality that the system can provide, but you always want to level up, right? And embrace it because in the end, you could have a cost savings, but you have to continue to embrace the features that the technology has. And you want to start small when you're implementing technology, any type of new technology. That would be my recommendation. So the next question. All right. So the best way to facilitate information system integration within a healthcare organization is to A, centralize all computer activities. That may not be possible to centralize computer activities. Um, it can be very restrictive and expensive if we look at that. So maybe that's not the best answer. B, use computer equipment from only one manufacturer. That is typically hard to do from a single manufacturer. That as well can be expensive and just is not always feasible in the complex healthcare environments. Not one system will do everything many times. So that may not be the best answer there. Use computer software from only one vendor. When we're talking about healthcare and you see only one, that may not be the best answer because there's no software that I'm aware of that can do everything, right? The clinical decision support, the appropriate use for imaging. That's a specific software that could typically do that. What we use in the lab, those are specific, softwares, what we use in coding, healthcare coding and CDI. When you see one, kind of think about the robustness of our healthcare systems. That's likely not the right answer. And then standardized data definitions and data structures. I would say that's essential for seamless information sharing and system integration across healthcare organizations. That is essential. So we need to ensure that we have definitions, right? Standard definitions that we all can understand, and data structure. So I would say the most appropriate answer is probably D, standardized data definitions and data structures. I saw a lot of answers for D in the chat. So I think everybody is in line with me on that. This approach enables different systems, regardless of the manufacturer and software vendor, to communicate, share, and interpret data accurately. There's, standardized computer language that we use within healthcare, that we use within systems so that we can integrate like that interoperability between our EHRs and the other tool that we're leveraging for different things. So that's very important. Standardization is the foundation for interoperability, data exchange, and enterprise-wide analytics. So that's extremely important for technology and sharing of information across different systems. So there we go. Next question. All right. Knowledge management is defined as A, the practice of explicitly and deliberately building, renewing, and applying relevant intellectual access to maximize organizational effectiveness. I'm getting tongue-tied here. Or B, the transfer of structured information between two computer systems. Or C, a movement explicitly use the current best available scientific evidence for managerial decision making. Or C, the planning, organizing, directing, and controlling of resources to accomplish goals and objectives related to distinct initiatives. So I think we had some A's in the chat. So A is likely the most comprehensive and accurate definition. B actually is simply about data transfer, not knowledge management, right? Specifically says transfer of structured information between two computer systems. So B is talking about interoperability and data transfer. So not necessarily knowledge management. C is refers to evidence-based, right? A movement to explicitly use the current best available scientific evidence for managerial decision making. So C, it really refers to evidence-based management or clinical decision support, right? Looking at evidence-based definitions to make a decision. It's related, but it's a completely different concept than knowledge management. And D is just general project management, not specifically about managing knowledge. So I would say the most likely answer to that one is probably A. Knowledge management is about maximizing an organization's effectiveness by intentionally managing and applying its collective knowledge. Yes. All right. So, and we did have several people, I believe, in the chat that had that particular option. So if you break down, hopefully that's what I'm trying to do, like break down when you get a question on any exam, at least for me, I try to break down each multiple choice option that's been provided to me and try to make sense of it from from a relevant viewpoint in line with the questions that's being asked to me. And so that's what I'm trying to do here for each multiple choice option we're getting, just to kind of break it down for you guys and what the question is asking. So hopefully that's helpful to you all. All right, so we can go. Which of the following is the reason that system support of outcomes, data collection, and analysis can be very complex? All right. So just kind of look at that question. So we're talking about the reason that system support of outcomes, data collection and analysis, so data collection and analysis can be very complex. All right. So A, the required data typically resides in multiple information systems and in manual systems. So kind of think about that particular concept when we're collecting and analyzing outcomes, it can be very complex in healthcare organizations, right? Data relevant to outcomes like clinical, operational, and financial can be scattered across various systems. So our EHRs, our electronic healthcare records, our laboratory systems, our building systems, they can be stored in many different applications, right? So that typically can make data very complex because it relies on multiple systems. And if you still have paper notes or offline spreadsheets, right, it can make it very complex. So integrating and standardizing these data the data for meaningful analysis is a significant technical and operational challenge in many healthcare organizations. So the required data definitely resides in multiple information systems. And if you have any manual, like I just said, spreadsheets, it can surely make it very complex. B, the functional departments are not integrated with financial information systems. That is partially true, but this is more of a specific example of a broader data fragmentation issue, I think, B. It doesn't capture the full complexity of data residing across both clinical and non-clinical systems, B. So B may not be the best answer because it's not really talking about the complexity of data residing, in multiple systems, and even if we keep some within a manual process. So maybe B may not be the best answer here. C, there's inconsistent medical terminology across different clinical systems. There definitely is the functional there is inconsistent medical terminology across different systems. Sometimes some systems may have SNOMED. SNOMED is a little different than ICD-10, which we're using within our coding systems versus custom codes. So there's definitely differences or inconsistent medical terminology depending upon how we use it in our systems, but it's about semantic interoperability and not necessarily about data collection and the complexity of that. So I would say C is probably not the best answer. And then D, variations exist between open system architectures, interface engines, and multimedia data entry. This actually refers to technical diversity and integration hurdles, D. So not necessarily about data complexity and collection. So I would say the best answer is likely A for this particular question. Okay, that's what we have. All right, 9. Membership of the IT steering committee should be comprised of A, the CEO, CIO, CFO, chief medical staff, and the chair of the governing board. While those individuals may be good to have, but maybe we're missing some key stakeholders here within A. B, representatives of the administration, physician leadership, information systems, and major user departments. I think that's the most important piece. All these individuals on B are key individuals to have a part of your IT steering committees. Your major user departments are key. So I would say at this juncture, B is the best answer. I see some people in the chat also selecting B. The CIO and senior system analysts, okay, they're the technical team, good to have, but that's an incomplete, I would say, IT steering committee. D, the CIO and outside technical CIO outside technical team is not necessary for your steering committees, I would say, and your consultants. Well, all right, if they're the end users, but it's a very limited selection of committee members. So definitely be administration for the overall strategic alignment and funding decisions. Is key to have physician leadership to ensure clinical priorities are met. Key to have information system management to provide that technical guidance. Key to have. And then your major departments, right, for B, to reflect the needs of the frontline users. Those voices needs to be heard to ensure success, right? So the other options are a little bit too narrow to meet the needs of the technology that has been implemented. So I would say B is the best answer. Yes, and a lot of people in the chat also picked the right answer for this particular question. So good job. All right. So next question here. Oh, 10. We're there. Selection of an information system in a healthcare organization should begin with. All right. So now we're looking for we're trying to select our information system for a certain service line. So A, meeting with several information system vendors to determine the scope of the available technology. Well, that may be a component, but I would say probably not the best approach here. B, hiring an information system consultant to determine the organization's strategic needs. I think that we could definitely hone in on what our strategic needs is ourselves. Only the organization and the leadership team that works there could really determine those strategic needs there. So C, development of an information systems plan that supports the organization's existing strategic objectives. I would say that's likely the best answer. The selection of an information system must align with the organization's strategic approach and goals, whether it's improving patient outcomes, increasing operational efficiency, or expanding services. Starting with a well-defined information system plan ensures that any technology chosen is not just the newest or most powerful, but the right fit for the organization's direction and needs. Um, I've used many applications, different applications that do the same thing in different organizations. But within these tools, even though at the basis of it, it can do the same thing, there are little nuances in it that strategically made sense for that particular organization. So um, C is, I think, would be likely the answer here because it's extremely important to align with your existing strategic objectives. Yeah. And then you can go, once you get that in place, you can, evaluate, your hardware and your software. But I think first and foremost, in the selection of that development of an information system plan is key here. So that is the answer. So number 11, I think we're almost done here. In the IT system development lifecycle, which is the most important step? Oh gosh, this takes me back to my students because I teach, like I said earlier, I teach computer informatics. So we talk a lot about the IT system development lifecycle. So which is the most important? The system analysis. So your system analysis is a critical step in your IT development lifecycle because it lays the foundation for everything that follows, right? It lays the foundation. So in this phase, the organization identifies the user needs and business requirements. It analyzes the existing workflows. It defines what the system must do. So that's really important, right? So system analysis is a critical step in the IT system development lifecycle. So system design, um, you know, just kind of depends on analyzing that particular software and looking at that design. It's not necessarily, not as crucial as the analysis part of it. System acquisition, uh, it's just kind of a component of it, and then system implementation, right? So if we're going to implement the software at the end of that life cycle. So I would say system analysis is the crucial component of the system development life cycle. Yeah, A. All right, last question here. An implementation that assesses structured databases of information, um, clinical information to aid a clinician provider in defining probable diagnosis or selecting appropriate diagnostic tests or treatment options. All right. So we talked about this in another question, right? Someone put it in the chat here. So a data warehouse is definitely not it. We're talking about a provider. So when we're talking about provider, clinical decision support system is it. I mean, that is the answer. A clinical decision support is specifically designed to access structured clinical data, analyze data using rules, algorithm. This is the tools I worked with the most, clinical decision support data that we leverage to identify documentation opportunities in the healthcare record. We use abnormal lab values in line with evidence-based definitions. So clinical decision support is definitely the answer here for this particular question. Clinical informatics is a broad field, right? Involving the use of IT in healthcare, not a specific application. And then a clinical data repository just stores clinical data, right? From various sources, but doesn't provide decision support. Um, and so the most logical answer here is definitely B. So is that it? Yeah. So that's definitely the most logical answer here. So I think clinical decision support tech tools are just fascinating, amazing. I could give you a whole presentation on that. Uh, but but I did put together an example. So since we have some time, I can actually go through. I don't know if any of you on this call have actually seen like a clinical decision support in action. So what happens with the clinical decision support application, which is where I have the most experience. So a physician is seeing a 65-year-old male patient with a history of hypertension and diabetes. So what the tool does, it can pull relevant data elements from the EHR. So it can pull the patient's age, vitals, lab results, diagnosis, medication, and it analyzed the data using clinical rules. So within applications that I've implemented, it was definitely a rules-based AI engine. So it can notice that the patient has blood pressures that are consistently elevated. It looks at the labs and if it shows, for example, when we're looking at kidney functions, it could show a decline in kidney function, and then it generates a real-time alert or suggestion. And so when we're looking at this from a clinical documentation integrity viewpoint, it's the same function. It generates an alert of what we call an AI query, notification, whatever appropriate terminology you want to use, different technology vendors will use different definitions, and you'll have your own data definitions. And so we're talking about a patient that has hypertension and diabetes. So it can alert from a clinical decision support, like consider ordering microalbumin test to assess for early diabetic nephropathy, right? So the patient may benefit from an ACE inhibitor. So it can use all that clinical criteria and provide suggestions to the clinician, to the provider, and look at any abnormal labs. So it can say, based on the latest guidelines, the patient A1C target should be less than 7%, right? So all of these rules and is stored within the back engine of it, which itself It's pretty fascinating. I worked with a lot of physicians, so we can actually create some of the rules that we were using in our application before we actually launched it. And then this piece, the clinical decision support piece, is very fascinating, and tools have come a very long way to streamline workflows and processes in healthcare, specifically from the clinical decision support system, viewpoint. So all good stuff there. But this was my last question here, I believe, right? What's the next slide? Yes. So I don't know if there's any questions and answers, or any questions that you guys may have. If you work in academia and you know anybody that teaches, computer informatics, honestly, everything we went through in the slides, they teach on that. So if you can sit in on the class, I think it would be very helpful if this is not one of your stronger areas for in preparation of the exam. So that's kind of all I have for you guys today. Any questions? Mhm. Okay, you're welcome. I don't think there's any questions, Jaime. And so, well, very good. Our pleasure. Thank you for your comments. Very kind. So I think if there's no questions, this was our last session for the day. I think we're ending a little early here. We can give you some time back. As always, you'll get the recording of the sessions from today, so you can have in your possessions and review them again at your leisure. But without any questions, I think we could stop the recording and, yep, you guys, and give you some time to start enjoying your weekend here.